everybody have lunch except us, except me? We'll be fine. Can you hear me okay? Happy Halloween. I see we have some people in the spirit. I'm hoping to get home for Halloween myself. I left my husband with 2 bags of good for children pretzels, because I figure if he's giving them out, he can get the evil looks. If I was there, I would be giving out candy. So we'll see what happens. My topic today with you is the ethics of clinical research. And what I'd like to do is basically 3 things. I'd like to talk to you a little bit about what clinical research is, and I'm going to be doing this more for the students in the room. So for those of you who are faculty and clearly well-versed and familiar and conduct clinical research yourselves, please sort of forgive me for that. I'll talk a little bit about what clinical research is and how it relates to clinical practice. I then want to set a historical context for the dilemmas that clinical research pose for physicians today. I'm a deep believer that understanding the historical backdrop for any contemporary moral problem in medicine is important, not only because of the adage that if you don't know history, you're prone to repeat it, but just because there are usually deep structural reasons why problems emerge, moral problems emerge in the practice of medicine. And those structural features usually have a long history. And I want to make sure that we understand what that long history is and how things were viewed in the 1940s, 50s, and 60s when clinical research was just getting started. And then finally, I want to talk a little bit about what some of the challenges are in clinical research today in more detail. In particular, I want to talk to you about something called the therapeutic misconception, which some of you may know as a term. I'll explain what it is, and we can talk about whether you think it's a problem or not. So let me start. Oh, by the way, there's no PowerPoint. I'm hoping the food and I hope you have caffeine in your sodas will keep you going. And we have about an hour, more or less. And I don't have, again, I don't know what's happened. Old auditoriums used to have big clocks to remind presenters about the time. And so all I have is my BlackBerry, which unfortunately I have to keep turning on to see what time it is. So if you see me doing that occasionally, it's because I'm trying to figure out where I am on the time clock. Okay, so what is clinical research? Well, there are many formal and fancy definitions of clinical research, particularly constructed by the NIH in order for people to be able to get funding for their work. But basically, what we're talking about here is research at the bedside with subjects who are patients. In contrast, say, for example, to research that's done with what we used to call healthy volunteers. You put an ad up and say, medical students, undergrads, please come. And we'll pay you X dollars an hour or Y dollars for 2 days in the hospital. That's not clinical research. That's biomedical research involving human subjects. But the people who are in those research projects are not patients. They're not anybody's patients. Somebody answers an ad or otherwise sees a sign up in the halls. I'm sure you see this all the time here in the hospitals. Research subjects wanted, healthy people or people with a certain experience who are not patients. We want to do some physiological research with you. We may want to do some very early drug studies with you, but you're not a patient. Now, there are ethical issues that are raised in research of that sort, research where the subjects of the research are not patients. But those are ethical issues about something else. Those are not ethical issues about clinical research. I'm just going to make it simple and say clinical research is research in which the research subjects are patients. They could be outpatients. They could be inpatients. There are all kinds of borderline cases that we could talk about, particularly in public health research. But I want to keep it tidy right here. So is everybody okay with that? We're talking about research that's done on people who happen to be patients either of an inpatient or an outpatient facility. And that's why we need that kind of patient, that kind of person to be the subject because of the nature of the research itself. We need to be studying people who have a particular disease or a predisposition to an illness or an injury. Now, What's the difference between clinical research and just personalized regular medical care? What's the difference? Well, arguably, by some people's account, there's a world of difference. If I go in to see my doctor, or I am admitted to a hospital here in Louisville, my expectation is that the physicians taking care of me, the nurses taking care of me, have as their primary motivation my medical best interests. And every decision that will be made about my medical care will be made with that objective in mind. It will be personalized to me. So my doctors and nurses have one objective, which is to make me better, whatever better means in the context of my illness or injury. And I have an expectation, a clear expectation, and the physicians and nurses have a clear ethical obligation to make their decisions. I'm simplifying this, but that's sort of the frame, right? That's personalized medical care. Dr. Dukas is taking care of me, and so I'm assuming that if he makes a recommendation about what I should do, that he's making that recommendation because he believes that that recommendation is in my personal best interest, and that's why it's called personalized medical care. It's about me as the patient. In clinical research, and again, for those of you who have already had experience with clinical research or are old hands at it, forgive me, there's something called a research design or protocol that lays out what happens to people who are in this research project. Everything from what drugs, if it's a drug study, what drug, at what doses, in what order, what diagnostic or monitoring test will be done, with what periodicity, with what follow-up, and so on. So the decisions about what happened to me if I am a patient who happens to be a subject in clinical research are not dictated around what is in my best interests. It follows the protocol. Everybody can see that's the deal, right? You come in, you're in the protocol, and what happens next to me, there may be a decision tree. If the patient subject has X response, you do Y, but it's still all in the context of the protocol. And instead of saying that the objective of what's going on here is to make me better, it may be that everybody is committed to making me better, but there's now another objective, which, depending on how we think about it, is primary, and that is to gain generalizable knowledge. This is research. It is science. Okay? We're following this protocol because that commitment to the protocol will allow us to draw inferences, not about what's happening with this patient, but about whatever it is that we're studying, so that we then have information that will allow us to take better care of other patients. Okay? So a whole new set of commitments emerges, which are the values and commitments of the scientific enterprise. Not only the values and commitments of being a clinician, which is what operates in personalized medical care, but the values and commitments that operate in the scientific enterprise. And the challenge to this day of the ethics of clinical research is how to manage those moral differences. In one setting, you as doctors and nurses to be have only one set of objectives to achieve. Okay? Making your patient as better as you can. In the other, you have two. And in some cases, maybe only one, which is to say the scientific objective. Now I have to ask a question, because I'm interested in this question for another reason. How many of you are semi-regular watchers of Grey's Anatomy? Okay. How many of you are semi-regular watchers of House? All right, here we go. Okay, that's me. Now, if you watch House or Grey's Anatomy, you will see occasional incidents having to do with clinical research. It'll happen occasionally. I'll give you, for those of you who've seen it, we can do watch it regularly. What you will see with great frequency are discussions or attempts or actual experiences of the doctors in both shows getting consent or failing to get consent from patients about medical procedures. Right? So you'll see Dr. Gray go in and she has to ask for consent from a patient, and sometimes this is done very sensitively, often it's ignored. We're actually doing a study, for what it's worth, we're actually studying how ethical issues in medical dramas are handled. And it's really, it's my favorite study ever, because I have to watch this for work now, right? My college student said, "What are you doing?" Because I took his box set of House, or actually his best friend's box set of House, and I started watching it, and I said, "I'm working." He said, "Yeah, I'm right. Sure, you're working." What happens very often at House, for those of you who know the show, is that Dr. House, who's a brilliant diagnostician, but absolutely a curmudgeon who doesn't believe in following any rule, no rule applies to Dr. House, or so it appears initially, that's the sort of superficial MO, is that he often either fails to get consent from a patient, or he lies to the patient so as to get the patient's consent. It's just pretty, everybody, would that agree, those of you who watch House? And it's always in the service of what's in the end in the best interest of the patient. Very rarely do we see a clinical trial of the classic clinical research kind of thing happening in either one of you. I don't know if any of those of you who watch Gray's Anatomy, Dr. Gray's mother, who herself is a famous physician with Alzheimer's, there was one discussion of whether to enroll her mother in a clinical trial for Alzheimer's, so that you saw the show. So that's a sort of classic conversation about whether we should enroll a person with a disease into a research study. In House, what you see is two things. You see experiments of one, right? They'll do something that's never been done before because he's brilliant, which he really is, besides being charming in a peculiar sort of a way. And they'll think up some very clever thing that has never before been done in a human being. Right? And then they will go ahead and do it. And it's never really framed as an experiment. Only occasionally is it referenced as an experiment. It's on that, but that's basically what we're talking about. And every once in a while, they decide they want to put somebody on a clinical protocol, and they have to call a doctor somewhere else and get the experimental intervention brought in. Now, from wherever it is that this rare new drug is being tested that's never been tried before, and so on. Now, one of the interesting questions is we've been looking at House and Gray's Anatomy is the extent to which the depictions are accurate of what goes on in medicine today or not. And there's been a little sidebar conversation for a while now about whether House bears, the experience of Dr. House and his fellows bears any resemblance to what operates in medicine today. And this is my segue to history, because I will tell you that in many respects, I actually have a view about how House fits with medicine today. House really fits with the medicine of the 40s, 50s, and 60s. And this is what I want us to think about. Now, informed consent for clinical for a clinical intervention like a surgery, right? Before you have surgery, someone's going to ask for you to sign a consent form. And then consent, of course, plays a critical role, or arguably should play a critical role, before you involve somebody, a patient, in research. But I want, for those of you who've seen House and Gray's Anatomy, to think about those shows as I take you back to the way medicine was practiced in the 40s, 50s, and 60s. I, fortunately, am old, but not old enough to take you back there myself. But what I'm doing here now is drawing on contemporaneous sources, as well as a wonderful oral history project that I had the honor to be part of, in which we interviewed some very, very distinguished physician academicians, physician educators, who are now in their 70s and 80s, but who were medical students or house officers in the 40s and 50s, about what it was like then. So what's interesting when you look at the findings of this oral history project and you look at the contemporaneous literature from the time, particularly when we talk to our respondents in this oral history project, these extraordinarily eminent physicians, at the end, all of them have had remarkably distinguished academic careers. What they all said to a man, and they were all men. We tried to get Harriet Taussig. I don't know if you know some distinguished women from that period, but there are obviously relatively few by comparison to the number of men, was that none of them recalled any obligation to obtain consent for patients during their training for anything. And they couldn't remember having to do this because, in fact, they didn't have to do this. So it wasn't as if they had faulty memories. They were accurately remembering what it was like at the time. During the 40s and 50s, if you all had been medical students or house officers in the 40s and 50s, you never would have been asked to go and get a patient to sign a consent form. It just would not have happened, or almost never would have happened, whether it was for treatment or for research. So here's what, I'm going to read you some quotes. I would read you tons more because I love them, but I'm going to try to restrain myself. Here's what one physician told us about his experience in 1945. In 1945, the doctor was king. It never occurred to a doctor to ask for consent for anything. Doctors weren't in the habit of telling patients anything either. Doctors were in charge, and nobody questioned their authority. And then he adds, which is interesting, now that seems egregious, but at the time, that's the way the world was. Now, I want you to think about whether that does seem egregious today. That's the way the world was. Think about, for those of you who watch House, does that seem egregious today? This unquestioned authority that physicians had in the 40s and 50s extended basically to all decisions about the management of a patient, including whether patients were to receive what was then considered an experimental therapy or otherwise be the subject of research or experimentation. Now, this is not to say that physicians were unconcerned with the welfare of their patients. Nothing could be further from the truth. I want to distinguish this. We found numerous, in this historical work, you find numerous references and in the oral histories to the fact that physicians were concerned with risk and with harm and with benefit. They thought about whether something was too risky, whether something was too harmful, whether there was a chance of benefit, but they didn't think about asking the patients for anything. So they cared. I mean, I don't want you to give the impression, and think again, for those of you who watch House, how house-like this is, right? They worried about getting it right. But they saw this as all their territory. And what's interesting is if these physicians in the 40s and 50s felt that they needed permission to try something new or to take some unknown risk, they did seek permission, but not from the patient, but rather from the chairman, again, men, of their departments. So the normative thing to do is that if you really were unsure in the 1940s and 50s about whether it was appropriate to try this really new thing on a patient, if you asked anybody, you asked the head of your department, or the head of your division, or the head of your lab. But it was within the chain of medical authority. You also didn't ask the hospital general counsel because that wasn't, at the time, a frame of reference either. Now, part of why we had this broad license in terms of physician authority over what would happen to a patient, making all those decisions with respect to experimental and innovative kinds of interventions, is because scientifically grounded medical practice was itself brand new. So now today we all talk about evidence-based medicine, right? Which is a very contemporary concept. In the 40s and 50s, new medical knowledge was basically, until the 40s and 50s, was largely accrued one patient at a time. In that empirical, experimental sort of, experimental in the sense of experiential. You tried something with a patient, it didn't work. If you still thought it might have a chance, you try it with another patient, didn't work again, you'd give up. If you tried it on someone and it worked, you'd say, that seems like I'll try that again and see how it happens. And knowledge accrued in this very informal way. It wasn't until 1948 that we actually have the first clinical trial, modern clinical trial, published in the medical literature. By that I mean a study in which patients are randomly assigned to two different treatments to see scientifically if we could establish whether one treatment was better than the other. And it's hard to realize, but it wasn't until 1948, according to the medical historians, that you see the first published results of a clinical trial in the medical literature, which is not to say that there weren't medical journals before that. They were more serious case reports. Does everybody know the difference? So we did 10 patients, and here was our experience with 10 patients, and we report this. Or we had this really fascinating case, and this is what we did, and look what happened. As opposed to saying, we had this hypothesis. We designed an experiment to test the hypothesis. We randomly assigned patients to condition A and condition B. Here were our outcome measures, and here is what our data support as the conclusion. All of this is brand new. Essentially post-World War II. All of NIH is a brand new phenomenon. The National Institutes of Health, funding mechanisms for systematic scientific inquiry at the bedside, this is all new. So given that, it's really not surprising that the way physicians understood about how to make decisions with respect to these new experiments was the way in which they made decisions about everything else. And I want to give you another couple of quotes here. Oh, by the way, let me give you a couple of quotes here because they get incredibly poignant. And I would share who these quotes are from in some cases. There's no problem not to, but I don't think for the younger people in the room especially they would mean anything. So here's a quote from a physician about something, this was a research project on pain management in post-operative patients. And he goes, "Mostly, I'm ashamed to say it was as if, and I'm putting this very crudely purposefully, as if you'd ordered a bunch of rats from a laboratory and you had experimental subjects available to you, a whole hospital full of them. They were never asked by anybody." We heard this over and over again. So here's a physician. He's talking about research that was done in the 1940s while he was a young assistant professor at Emory University. And this was research with patients who had bacterial endocarditis, which was at the time invariably a fatal disease. What they were doing was actually developing the technique of cardiac catheterization. They were trying to figure out how to be able to do cardiac catheterization. And they were trying to see whether cardiac catheterization would allow them to compare the number of bacteria in the blood at different points in the circulatory process that could help them understand better a disease like bacterial endocarditis. So here's the quote. It's a little bit long, so bear with me. "This is something I wouldn't dare do now. It would do no good for the patient. They had to come to the lab and lie on a fluoroscope table for a couple of hours. A catheter was put into the heart. A femoral needle was put in so we could get femoral arterial blood, and so on. All I could say at the end was that these poor people were lying there, and we had nothing to offer them. And it might have given them some comfort that a lot of people were paying attention to them. Sometimes they even thanked us. I don't remember ever asking their permission to do it. I did go around and see them, of course, and said, 'We want to do a study on you in the X-ray department. We'll do it tomorrow morning.' And they said, 'Yes.' There was never any question. And they thanked me." Okay? And then he goes on. "If I were ever on an ethics committee today, I would never have passed that particular study." What we heard over and over again, and this is not just in work that I've been privileged to be part of, but in the work of medical historians more broadly, is that physicians recognized the vulnerability of patients, particularly the sickest patients. They understood that. They saw their responsibility, and I really want to emphasize this, they saw their responsibility to think about risks and benefits, and basically mostly risks. Is this too risky to do? Was the ethical question they asked themselves. Now, another one of the people that was interviewed for this project in reflecting on what was to become a controversy in the 1960s, which was the ethics of research on prisoners. So until the 1960s, it was commonplace for drug research to use as subjects prisoners. And there was a big controversy about, we could have a conversation about it if you'd like, a big controversy about the ethics of using as research subjects prisoners. And in fact, this issue was just revisited about a year ago by the Institute of Medicine. It remains an unsettled question. But you need that piece of background to understand this quote from this physician, because he's referencing the controversy that erupted in the 1960s. One of the really ludicrous aspects of talking about a prisoner being a captive and therefore not being an appropriate ethical subject for research and therefore needing more protection than others is there's nobody more captive than a sick patient. You've got pain. You feel awful. You've got this one person who's going to help you. You'll do anything, he says. You're a captive. You can't, especially if you're sick or even dying, discharge the doctor and get another one without a great deal of trauma and possible loss of life-saving measures. That's being a captive. Now, it's this reality of vulnerability and dependence that you hear all the way through these conversations that I want you to think about. Has that changed at all? Are physicians less powerful because patients are somehow less vulnerable? Is somehow being sick less scary in 2000 and what are we now? 7 than it was in 1947? Isn't it just really scary to be very sick and to be worried about whether you're going to make it? Or maybe whether you're going to feel well again ever? We don't have to make it quite so dramatic. Are you somehow less dependent because the internet exists and you can go on the web and see what you can find out about what's wrong with you? So has vulnerability and dependence changed at all? Here's another quote. At the time, this is 1956, and this is what was then called the Moffitt Hospital in San Francisco. It's the University of California, San Francisco system. At the time, the adrenal gland was hot stuff. ACTH had just become available, and it was important as a tool for exploring the function of the adrenal gland. And that's the project I was involved in during that year. I was a medical student. The study of adrenal functions in patients with thyroid disease, both hypo and hyperthyroid disease, and boy, was I excited. So what did we do? I'd find some patients in the hospital, and I'd add a little ACTH to their infusion and collect urines and measure output of urinary corticosteroids. I didn't consider it dangerous, but I didn't consider it necessary to inform them either. So far as they were concerned, this was part of their treatment. They didn't know, and no one asked me to tell them, and that was fine with me. Okay. Now, again, for those of you who do watch House, think about how they operate. Think about what you observe. Right? Think about what you do. Okay, so all of this is going on in the 1940s and the 1950s, and it is the case that this way of doing things was very entrenched, and so you started adding this exciting new scientific medicine at the bedside stuff, and it just sort of fell in to the way in which things had always been done. But it wasn't as if thoughtful, reflective physicians were not raising questions about whether this is the right thing. And one of the most remarkable such people, a sort of unsung hero, I think, in the history of medicine, is a person, relatively unsung, a person named Otto Guttentag, who was a physician also at the University of California, UCSF Medical School. And he and his colleagues in 1951, convened a symposium. And the symposium, like something Dr. Dukas could convene here today, the symposium was called The Problem of Experimentation on Human Beings. And for that symposium, he delivered a paper which he subsequently published in Science in 1953. Which I guess, I actually should check with the historians, was a big deal journal then as it is now. Now, Gutentag constructed his paper around a comparison between what he called the traditional role of the physician as healer. So those of you who are going to medical school, presumably you've come because you think of yourself as someone who wants to be a healer, according to Gutentag. The traditional role of the physician as healer. And he wanted to compare this, or did compare this, Dr. Gutentag did, with the relatively new role, as he saw it, of physician as medical researcher. And he referred to the former, the physician as healer, I'm using his words now, as physician friend. And he referred to the latter, physician as researcher, as physician experimenter. Just think of the word. So, physician friend, physician experimenter. And he specifically laid out, first, the manner in which medical research would conflict with the traditional doctor-patient relationship. And this is what I was starting with in the beginning of my comments. This is Dr. Gutentag now, 1953, by the time the paper is published. Historically, one human being is in distress, in need, crying for help, and another fellow human being is concerned and wants to help. And the desire for it precipitates the relationship. The desire to be helped and to help precipitates the relationship. Here, both the healthy person, the helper, and the sick person are fellow companions, partners to conquer a common enemy who has overwhelmed one of them. It's very lovely language, right? And also morally very powerful. I'm continuing here. Objective experimentation to confirm or disprove some doubtful or suggested biological generalization is foreign to this relationship, for it would take advantage of the patient's cry for help and of his insecurity. To prevent what he called the experimental, this is 1953, the experimental exploitation of the sick, he envisioned the following arrangement, or proposed it. Research and care would not be pursued by the same doctor for the same person, but would be kept distinct. The physician friend and the physician experimenter would be two different persons as far as any single patient is concerned. The responsibility for the patient as patient would rest during the experimental period with the physician friend, not the physician experimenter. So that's what Gutentag was proposing as the solution to essentially the moral dilemma that he saw between the traditional ethics of the doctor-patient, nurse-patient relationship and the ethical demands and constraints of what we now call clinical research. Gutentag's vision was never enacted. It's not the way it went. Okay? The story didn't go the way he had hoped it would go. And in fact, what we have today, and there are good reasons why we have it this way, is indeed a conflation in many cases of the physician experimenter and the physician friend. That's just what happens in a great deal of clinical research. Not only in academic medical centers, but increasingly in private practices around the country, where private practice physicians are in fact, in some respect, involved in recruiting their own patients for clinical research. Very large operation. So, what did we do as a society, and what did the medical profession do as a profession to try to deal with the moral tension that Gutentag identified, okay, but whose prescription was refused for how to handle it? We turned to two things, right? why did those physicians in the 30s, and the 40s and 50s say it would never happen today, or I would never do this today, the way we did it then? Those two things, and I'm oversimplifying a lot, but the two main things was a regulatory structure that was created. How many of you know what institutional review boards are here, IRBs? So these are research review committees required by federal law for federally funded research and extended voluntarily by most institutions that do research to all research, regardless of who or what is funding it. These IRBs have the job of overseeing research that's proposed. So instead of a physician going to his or her department chair for permission to do a risky or new experiment, okay, the physician must go to this committee to get approval. So that's one mechanism that was set up to manage the conflict. Kuttentag said, eliminate the conflict. Have two different kinds of people involved for any particular patient. The societal response, the professional response, was forget that. We cannot do that, but we will find alternative mechanisms for managing the conflict. One is oversight by a committee, and here are the rules the committee has to follow. And this is the response that emerged full force in the 1970s. And the other is, let's elevate this informed consent thing. There's a very long history behind both of these social responses, which I don't have the time to go into, but the general idea is, let's make sure that patients who would be asked to be subjects understand that they're being asked to be research subjects and decide for themselves whether they want to get into this dual track. And the connection between these two social responses, the institutional review board committee structure and the informed consent mechanism, was that remains that the institutional review board has the responsibility for overseeing that consent is properly obtained. That's one of the responsibilities of the IRB, not the only one. Okay, so that's the history, societal responses, and now the question is, does it work? Right? Do these two mechanisms work? Where work would be defined itself, how you define work is itself controversial, right? And there's, but you would think that at very least work would mean that patients who become subjects at least understand the difference, that they're no longer in a track with their patients that could be defined as personalized medical care, but instead that they're in a research project where a lot of the decisions that are taken are according to a script, including, for example, if you're randomized to the active agent or the placebo, or to the traditional agent and the new one, or the new surgical procedure or the old one, that they get that, right? And in getting that they understand basically two key things, or so it's argued. One is that it isn't personalized medical care. Put simply. And the other is that they know that it's related, that the judgments that are being made are not being made about me. Right? Now, what we've learned during more recent research about the contemporary situation is that, in fact, a lot of patients who are subjects of research don't get those two things. And this is the term I obliquely referenced earlier called the therapeutic misconception. It's a term that was coined by a team of researchers, a very, very fine team of researchers, a while back, and there's now a substantial body of literature that really supports the view that a lot of patients who are enrolled as research subjects in clinical research, the estimates are very poor because we don't have large population databases for this, but it could be as much as half of patients involved as research subjects don't get the critical difference. They may say, I'm in research, but if you ask them what the purpose is of this, about half of them will say the primary purpose is to make me better. Right? They may say, and it'll also help other patients down the line, but the main purpose of this is to make me better. So to give you some quotes from patients today, to sort of offset doctors of over a half century ago, you hear things from patients like, basically, we trust Dr. Smith. There was no reason to get a second opinion from another doctor. He would only tell me to do something if it was good for me. This one I love, because she says, "Oh, I love that man. He has kept me alive, and I obey him. And I do what he tells me to do. I love that man." Another patient, "I have this attitude. They know what they're doing. They wouldn't have you do this if they didn't know what they were doing, and if they didn't know it was good for me, and that's my attitude." These are patients today. Now, why do patients have this view? People sit down with them, and they have this whole long conversation with them, and they explain to them, this is a research project, here's a 20-page protocol, and so on. Well, first of all, one partial reason is the language we use. We have data that says, remember when I used the term physician experimenter, we never say, would you like to be in a medical experiment? Has anybody ever asked a patient, would you like to be in a medical experiment where we're going to randomize you? No, we say, would you like to be in a clinical study? Would you like to be in a research trial? Right? We actually have data, I love data, we have data that pretty much provide a good evidence base for the fact that when you say to people, would you like to be, what do you think an experiment is? They say, oh, it's a terribly risky thing, right? I wouldn't want to be in an experiment. What about a clinical study? Oh, clinical studies are good. That's new stuff. That's good. That's good. And clinical trials, even better, right? Clinical trials are great. That means I'm going to get the newest, latest, best stuff. And in fact, okay, that takes us to our second reason why many patients still don't get it, quote unquote. They have this therapeutic misconception, this misconception that it's really all about therapy for them rather than about generalizable knowledge for others. And the second reason is there is a chance that this is good stuff, right? The physicians and the scientists and the nurse researchers who were involved in the clinical research wouldn't be doing it if they didn't have a hypothesis, okay, that they were testing out something that might be better for this condition, right? Now, it's true that in the clinical research, especially if it's a randomized clinical trial, you may get the placebo or you may get the old stuff, but you also may get the new stuff. And in fact, the new stuff might be better. So that's another reason. It's like everybody thinks the new stuff. Otherwise, the physicians, the nurses, the scientists wouldn't be doing the trial, wouldn't be doing the study if they didn't have an operative hypothesis that they were going in a positive direction. And the third reason, I think, goes back to what I submitted for your consideration in the beginning. Do you really think that patients are any less dependent, less scared, more desperate, if their medical circumstances warrant it, than 50 years ago? Probably the single biggest reason why something like the therapeutic misconception is so enduring is that it's sort of embedded in the human psychology of being ill and of being in a healer relation with an ill person. It's really, really difficult, okay, to say to somebody, look, that's it, you're done. Okay, there's no chance at all that you can get even a couple extra weeks. I'm making this very dire on purpose. And we just want you to do this because it'll help other people. And then the patient pushes back. You do this with standardized patients, for example. The patient pushes back. Are you telling me there's absolutely no chance that this new drug could, give me a couple more weeks? Well, put it that way. Well, it's very remote. We don't want you to think that, but okay, obviously we wouldn't be doing this. We think the doses are too low to make a difference. But wait a minute, didn't you just say that there's some chance that this could be better than anything else I've ever had before? Well, could be, but don't think that. Well, that's like saying, you know the old jokes about don't think about the apple in front of you, right? Pretend it's not there. The tricks that I'm looking at. Are you a litigator? No. That the courtroom tricks, you know, don't think about what I just said, withdrawn, right? Withdrawn. Everybody watches, I'm into TV references, Law and Order, and we'll have the district attorney, whatever his name is, say something he knows he shouldn't say because it leaves an impression on the jurors. Withdrawn. The jury is instructed to disregard that comment. Okay, so I'm not saying that I think it's quite different in the clinical relationship. I don't think the physician intentionally wants to leave something there and then withdraw it. It's just that you get pressed by this patient who wants so desperately to believe that this is going to be better, that there's a chance. And actually, as just an epistemological matter, there is some chance, right? You can't say zero chance. There is a chance. The minute you say that, if what the person wants to hear is, that means there's a chance, then that's what stays. And that's enduring, I think. I think that's very difficult to change. So the last part is, if in fact the scenario and the sort of claims and descriptions I've laid out for you, if you find that plausible, what are we supposed to do about this, if anything? And maybe I want to just have a little conversation with you that's a bit more radical. So what's wrong with this? So what if patients are sometimes not exactly clear about the clinical trial, what it means for them to be in a clinical trial? Is that so terrible? Right? What do you think? Is it so bad? Right? The patient doesn't quite get it, or the patient sort of gets it intellectually, but in her heart she really, really believes that the reason we're all doing this is because there's this tiny chance that she might get better. Okay? And is that why take that away from her? Hit her over the head with the blunt truth when we don't even know what the blunt truth is. Yes?
Well, I suppose that one good is it keeps the medical system going.
Well, we need the new knowledge. Oh, I'm sorry. So one comment, the comment is it keeps the medical system going. And I should have prefaced this. Clearly, clinical research is a good thing. Medical progress is a good thing, or we wouldn't be doing this. And there is this problem that at least right now we can't get to the right place we need to get to in advancing medical knowledge without a stage of experimentation on human beings. Maybe someday we'll have incredible simulation models and we'll be able to skip this whole thing. But for right now, it's an ineliminable step towards medical progress for many lines of treatment, right? So it's a good thing for all of us to do this stuff. Yes, I'm sorry, Steve. Go ahead.
I want to follow that up with a comment that the psychology of the patient is not unlike that of our betting on the lottery.
Oh, no. I mean, right.
Enormous denial. You know, all
there's a chance.
the stats against us. That's
right.
Not me. I mean, I'm in this little bit that's going to benefit.
Sure.
And the combination of denial with hope. You know, we need a good outcome.
And to be a good clinician, I mean, for those of you who are clinicians in the room, to be a good clinician is striking a balance between being honest and continuing to support the patient emotionally, where hope is an incredibly valuable, positive emotion, right? So that's part of the art form of being a healer. Yes, Steve, I'm sorry.
But connected to that is the issue of trust.
Mm-hmm.
And also it lends itself to disappointment and loss of trust.
Right.
Not only clinical research, but clinical practice depends upon trust between physician and patient.
Right.
And that's the main reason why this is a significant problem. It may not keep clinical practice going. It may, in fact, interfere to have patients just unclear
Right.
about what's actually going on.
Right. So one argument is this is a bad thing because it's bad for the enterprise of clinical research overall. Patients will get wind of this. Of course, this has been going on that way for a really long time now, right? A really long time now. And I actually am a big advocate of the line that the argument that you've just put forward. But to argue against that, it's been going on for a long time this way, and people are still clamoring, desperately trying to get into clinical trials in most cases, right? I'm concerned about time because it looks like we're losing folks. So I'm wondering whether we want to stop. Yeah, 1 o'clock test. Do you want to go to 1:15 or do you want to stop it?
Questions and answers at this point.
Okay, so we can just keep going. Yes, I'm sorry. Was there another comment that? Yes.
I was just going to say that in terms of understanding and accepting intellectually and emotionally, how could you ever really know? There's no test for that.
If they really get it. Well, it's very interesting. A lot of this work has been done. Much of the work trying to understand what patient subjects understand. It is tricky methodologically to do this work. It's been done by social scientists and by psychiatrists and psychologists, largely. The good work has been done by social scientists and psychiatrists and psychologists for good reason, because you're talking about needing to figure out very, try to get as valid insights as you can into what people believe in and hold dear, their emotions and their thoughts and their attitudes, and that's tough. And there are all kinds of questions about what did people believe at the time when they said yes, what did they believe over time. All of that stuff can change. They could have understood it in the moment intellectually, but then they reconstructed it in their head. And depending on whether you're looking at this from, say, a legal standpoint, did we get a valid consent at the time the person signed the piece of paper versus the sort of ethics of the whole enterprise, you'll be more or less worried about different points in that process. So there's that question as well. Yes, please.
We could contrast the dynamic between a research program that's integrated in the site where the person receives usual care,
Right.
versus being referred to a research center.
Right.
Or other entity.
Right.
It seems to me that contrast is quite stark.
Well, it's interesting. I have to go back and look to see whether any of the... Yes, the question is if you're involved in a research project at a site where you receive your ordinary medical care, or if you're referred someplace to something that's labeled a research institution, that's a stark change in your care, and you would think that would really shake it up in the mindset of the patient, that now something's switching. I assume I took that as the inference, that you're going from personalized medical care that you got from this person who's been taking care of you since you had this diagnosis, or maybe for 30 years or whatever, to the research hospital to join the protocol. And I don't want to answer because this is not fresh in my mind. I'm trying to reach back to see whether any of these studies have been done, for example, at the clinical center at NIH, where everybody's supposed to know that they're going to, the clinical center is the hospital of the National Institutes of Health, in which everybody in that hospital is on a research protocol. That's the characteristic of that institution. It's largely characteristic of many, say, academic cancer centers that most everybody is on protocol, but it's not 100% the case the way it is essentially so for the clinical center at NIH. And I don't know if the difference, but the thing is, it's not like in these studies where half the people don't get the sort of key elements of the difference, that they don't understand that they're in research. They do get that. I mean, if you ask them and you say, well, are you in a research project or not? They'll say, oh, yes. And then you ask, what is the purpose of that research project? What's the main what's the main purpose of it? It's to make me better. It's to get me the newest stuff. It's to get me the new experimental drug. So what we're learning is it's not enough to go to your question of how do we know what they know, or what they say and what they understand. You have to figure out what it is you want them to understand and find out if they understand that. So early on in this work, people said we need to figure out if they understand that they're in research, and that'll be good. Because there was a time when people clearly, when you talk about the 40s and 50s, didn't know they were involved in research at all. They just didn't know, the language wasn't there. So now we did those studies. Oh, good, people know that they're in research. But then the question became, well, wait a minute, maybe we should find out what they think that means to be in research. And then that next layer back is where it's revealed in these studies that a lot of these people who say, oh yes, I'm on a research protocol, right? And here's even the number of the protocol, right? Here's the number, and I find it on the website and all that kind of stuff. Still have this view that the main thing that this research project's going to do, what everybody's about, all these doctors and nurses, remember the reference to when the physician was talking about the cardiac cath lab and how guilty he felt, but the patients were like feeling good because all these people were fussing around them? Some of that lingers in the context of the contemporary clinical trial. Often there are many more things that happen to you because you're in a clinical trial that can be understood as all these people are doing stuff on my behalf. Look at all the attention I'm getting. And the thing is, it is the case that patients in clinical research often do get. That's why this stuff is not, often do get better medical care, or at least more attention that has in itself some value in terms of making people feel cared for. So it's not like, that's why I posed the question. So maybe this isn't so terrible, right? And anyway, Steve, and then we should probably...
Well, I just wanted to suggest that there is one more, I would say, really important source of therapeutic misconception, and that is it's not just held by patients, it's held by doctors.
Sure.
There are many times in the IRB where we change language which either promises or strongly implies benefit from phase 1 clinical trials.
Yeah.
Largely because I think the researchers believe it.
Right.
And of course, if they believe that this is going to benefit patients, that's going to be transmitted there.
Right. No, I was trying to explicate that. I mean, it's sort of built in, it's exactly so, and it's very difficult. One of the experiences I had that was really enlightening is with a colleague who was very skeptical that this was a problem. He's a radiation oncologist, and he was very skeptical that this whole therapeutic misconception thing was a real phenomenon. And so we got involved in a project which is completely limited in terms of its design, its usefulness, because we were only looking at paper. We were looking at consent documents. We were not looking at what doctors and nurses who were recruiting patients into trials actually said. So this is as bad a data set as, sort of basis you could have. We only were looking at the consent forms. We took a systematic sample of a huge number of consent forms, and we had experts in the area, whatever areas they happen to be, evaluate they had the protocol, which was what went to the IRB, and a copy of what went to the NIH grant application, explaining the science based on which they received the money. And then we had the relevant medical scientists compare the consent form, like what was said to the patient, some of them horribly long consent documents, the consent form in terms of what it said about the prospect of benefit against what was in the grant application and in the IRB application. And it made a complete convert out of this colleague of mine who was a skeptic because he was appalled. He said, they're saying that, right? This is like the thinnest read. It barely got through the study section. I wouldn't have even funded it because I don't think, because of course right away your personal subjectivity comes in. This was stupid. Why did they even fund this? But okay, they funded it. I guess it's plausible. If you assume this, that, and the other thing, which I think are wrong assumptions, you have to work with people's prejudices in any area or predispositions or biases and about what hypotheses are likely to have a good chance of working or not. But it is the case, and I actually think some of it is because they believe it, but some of it is because it's hard to say, if you write out what it really is, it's harder to say it because you worry that, God, when I read it, it sounds pretty uninviting. And the whole point here is we're trying to get people to agree to be in these studies, and we need them to be. So, yes, please, David, why don't you ask the last question, and that'll be...
Parker, first has to do with what Paul was pointing out, is that the whole notion of hope really has a very powerful role in the sense for patients enrolling in clinical trials, and oftentimes people will have this
No,
will
absolutely.
optimistically push
Yeah,
forward.
that's right.
There's got to be some good of this. And by doing that, they can go ahead and have that emotional and scientific buy-in. That they wouldn't be doing this if it wasn't going to help in some way. That's part one.
Yep.
And that was just a comment. But the second part is actually more disturbing from what I saw when I was in Philadelphia. The Faden Practice Center was actually in the same building where Glaxo Sciences was. And there were commonly many trials that were going on. They even had their own intensive care unit, just in case things just didn't go so well. But the thing that was really surprising is sometimes we got patients who completed doing many-month or a year-long drug trial with Glaxo, and you would ask, well, who is your primary care provider? And they would answer, Glaxo. This is where they were receiving their universal health care, so to speak, where they would be getting physical exams, laboratory examinations, and things like this. So the confusion between the hats of the clinician as caretaker friend and that of the scientist who is experimenting on somebody gets blurred even more so when they're so disenfranchised from a healthcare system that doesn't work adequately. They actually go to the scientist and, hi, experiment on me, pay me, and care for me.
Right. It's a pretty dramatic example. I think maybe we should just stop on that note. So I agree. Thank you all very much.